In this study by Delianis and colleagues, they looked at 327 patients over a 6-year period, all with a diagnosis of cleft lip or palate. They examined the hospital records and tried to determine the compensation received by the hospitals and the physicians for these patients. Not surprisingly, they found that the hospitals made a substantial amount of money on these patients. For a lip, between $5,000 and $10,000, and for a palate, between $6,000 and $13,000, with very reasonable margins on that money compared to their costs. Interestingly, physicians made approximately 1/10 of that in their compensation. So, what they came to in terms of their conclusions was that hospitals, because of their compensation in even these cases, should more willingly provide administrative support to cleft lip and palate teams. Well, fortunately for us, that's already happening. Whatever happens with healthcare in this country, it's very clear that more children will be covered by some form of insurance, most frequently the government insurance, either Medicaid or Medicare. Accordingly, hospitals have recognized this as an opportunity, and as the margins go down on individual patients, they've realized the key to financial success is patient volume. The only way that they're going to be able to keep up with that volume in children's hospitals is to massively expand their facilities and the providers that they hire. Unfortunately, it's frequently very difficult to go through a medical school to hire all those providers due to their financial limitations and their administrative needs. So more and more commonly, children's hospitals have begun forming PSOs, or physician services organizations, to more or less directly finance these physicians through the medical school. That is, the hospital is financially responsible for the physician. Along those lines, increasingly they are providing free of charge the nursing support and the physical space to care for these patients in the cleft lip and palate clinics. This is going to be increasingly important as we enter the new era of what we call APDRGs. That is where there is one set payment, just one payment for a diagnosis, depending upon severity. Additionally, there are going to be adjustments in those payments for quality outcomes. So hospitals are now going to be incentivized to provide that high quality care to the large volume of patients. For better or worse, we're entering a new era of healthcare, an era where the hospital and not the medical school are now the focus of our activities.